Ladies and gentlemen, a very good afternoon. I'd like to congratulate the conveners of this conference for convening the conference on an extremely important subject, and sincerely regret my inability to be here with you this afternoon. This conference is about security in health and a certain specific aspect of health security. But before we go on to that, I think it's important to appreciate that the contemporary understanding of security today scopes beyond wars and human rights abuses and genocide to a people-centered view of security along the lines of the norms that have been coined by the UNDP and the Commission on Human Security. This is a holistic concept which includes water, food, energy, environment, and health security. And indeed, in overpopulated countries such as the one that I come from, demographic security is a very important part of such security considerations. There are three aspects of health security which are extremely important. One of them is ensuring financial risk protection and financial security for health. The second is healthcare security, and the subject under consideration and within the remit of today's discussion is epidemiological security. Within the scope of epidemiological security, we tend to address public health emergencies of national and international concern, emerging and re-emerging infections, and biological or chemical emergencies, whether they're accidental or terrorism related. Whilst I speak for a few minutes about epidemiological health security, I'd like to touch upon two aspects. I'd like to talk about global and domestic information systems, and then very briefly, I'd like to talk about the broader health systems issues and constraints which are an impediment to ensuring epidemiological security within the ambit of health. With reference to a global and domestic information systems, I think it's important to appreciate and understand right at the very outset that domestic information systems within the health sector comprise a plethora of different arrangements. So if you look at a country context, there is surveillance happening in different streams, there's vital registration, there's infectious disease surveillance, which is fragmented into different pockets because of the manner in which vertical public health programs have been initialized in the developing countries. There is surveillance of chronic disease risk factors as part of surveys. Then there is surveillance which is being conducted in registries. Apart from the surveillance activities of a domestic health information system, there are management information systems which are linked to health facilities. There are periodic surveys which are conducted by different agencies in different cycles. They are institutionalized by different development agencies. So the World Bank has its Social and Living Standards Measurement Survey. The UNICEF tends to support the multiple indicator cluster surveys. The USAID, a bilateral agency, promotes the demographic health surveys in many developing countries. And then outside of these health information systems are a number of research activities, academic research activities, which have to do with epidemiological research, which have to do with health systems and policy research and clinical trial and so on and so forth. So within this diverse space of health information systems, there are a number of gaps in each area, and I'd like to focus on gaps that are relevant to the subject under consideration today. The first gap, which I think is of critical importance, is the fragmentation of infectious disease surveillance systems and the lack of integration. Then there are attributes of infectious disease surveillance which have not been honed for outbreak and emergency situations. So countries may have capacity to conduct active surveillance visits at health facilities. They may have the infrastructure to collect specimens from laboratories and to transport and conduct testings. They may have functioning channels of data reporting and analysis and dissemination, and they may have defined indicators to measure surveillance quality, and they may have infrastructure for training and capacity building. But as I said earlier, they may not be honed for outbreak and emergency situations, and all these capacities may remain fragmented within individual disease domains. And this, to my mind, is one of the core impediments and country constraints that needs to be addressed through consolidated capacity building efforts supported by international agencies. Secondly, and with reference to domestic information systems, there is, of course, a gap in capacity to confirm clinically diagnosed cases of reportable diseases because of gaps in the public health laboratory network within countries and many developing countries of Asia. There are, of course, inabilities to tap data from the private sector. For instance, the country that I come from has a large and vibrant private sector with very little linkages with information system reporting. Then again, citing an example from my own country in terms of a health information system constraint, there's absence of a legal system to mandate notification of priority diseases, and my sense is that it may similarly be the case with many other developing countries of Asia. Again, from my own country, there's lack of a regulatory framework for laboratory practice. There's absence of legal requirements to report death per se and report cause of death in death certificates using the ICD classification for coding. And it may similarly be the case for many other developing countries for Asia. But by far the most important constraint with reference to the subject under consideration is the absence of apex institutional arrangements to collate, consolidate, analyze, interpret and report data and information. So there are a number of ad hoc, overlapping and standalone data systems, and then many donor-driven data activities, but the apex arrangement to collate and consolidate them and then analyze and make triangulations and report data and communicate them to the right agencies in a timely manner is an area where there are significant gaps. To add to these, there are gaps in mechanisms to communicate data. And again, along the lines of the constraints that we're talking about, and citing an example from my own country, there's lack of uniform standards for ensuring quality in data reporting. Very importantly, there are poor linkages with the country's disaster management system. So during the earthquake, these information systems had to be structured de novo in terms of the linkages with the country disaster management system. And I'm here referring to an earthquake that happened in Pakistan in 2005, which claimed more than 80,000 lives. Again, our experience from this particular incident and from the subsequent outbreaks of avian flu gave us the sense that there were inappropriate intersectoral linkages for data sharing across sectors, particularly foreign affairs channels, transport, home affairs, and the agriculture sector. Our country, and I'm sure many other countries, therefore have limited capacity to comply with international health regulations of 2005 of the World Health Organization. And the country does not make adequate use of global surveillance norms and capacity building tools. Most importantly, to my mind, technology has not been strategically leveraged to enhance connectivity without Pakistan's data systems, despite the existence of an excellent telecommunications infrastructure. And my sense is that this may be the case in many other developing countries of Asia as well. However, most importantly and critically is a culture of decision-making which is based on conventional personal interests and anecdotal evidence or political expediency as opposed to evidence. And I think this is a core institutional attribute in governance which needs to be shaped for health security and for broader social sector outcomes in many countries of Asia and indeed in my country.